Welcome to our third Society for the Advancement of Transplant Anesthesia webinar. Really excited to see the large group of people who have been able to attend today this evening. Thank you for giving us part of your time. As you know, we've done two previous ones. One was done on COVID, and the most recent one was done on lung transplants. This is our first one on liver transplant, and we're really excited today to have two excellent speakers, which our moderator will be introducing in just a moment. Real briefly, I just want to kind of remind everyone why we're here today. This is thanks to the support of our great societies, the Society for the Advancement of Transplant Anesthesia, which is the only society dedicated for the advancement of this field, and the very unique of all organs, transplant and anesthetic management. If you haven't joined already, please, I strongly recommend that you do join, going to our website, transplantanesthesia.org. I also do want to give a plug for our next upcoming, this is actually sponsored by our Vanguard Committee, expert lecture series. This is going to have our president-elect, Dr. Ted Sakai, talking about living donor liver transplant, donor management. Details on how to get access to this webinar will probably be coming in email in the next week following the completion of this webinar. Without further ado, I'm going to introduce the moderator for this pro-con debate from University of Nebraska, Cale Castle. So I'm going to stop sharing and turn over to Cale. Thanks, Cale.
Awesome. Thanks, Ryan. Welcome, everyone. I think this is going to be a great discussion today on the routine use of anticoagulation in liver transplants. We'll just do some introductions and then get started. The format will be 20 minutes for the pro, 20 for the con, and then 10 minutes for rebuttal, and hopefully about 10 minutes or so at the end for questions. And if you have questions, please just go ahead and throw those in the chat and we'll get to them at the end. So without further ado, taking the pro today is Dr. Ramona Nicolau-Rodicu. She's an associate professor from the University of Miami and is chief for the division of solid organ transplant there. Like I said, please make sure if you aren't already, stay muted for this. We'll put questions in the chat and we'll get started from there. So without further ado, please take it away.
Hello, good evening. I'm sharing the screen. So I'm doing the pro debate for routine anticoagulation during liver transplantation. Everybody's hearing me? So I do not have any conflict of interest and nothing to disclose. Traditionally, perioperative bleeding complications were a major concern during orthotopic liver transplantation, but a decline in transfusion requirements has been reported over the last decade. In the recent years has been an increasing awareness towards perioperative thrombotic complication. All this is due to a changing concept of cirrhotic coagulopathy, to a rebalanced coagulation, to a deficiency of both coagulation driver. What tests we have to analyze this balance? The most common test used is INR, which measure the procoagulant sides of the coagulation cascade and not the anticoagulant side. The use of antithrombotic measures should not be delayed because of a prolonged INR if the patient can be seen to be actually prothrombotic. What other tests we have? Thrombin generation test, a promising laboratory tool, can be performed with or without thrombomodulin and allowed to analyze natural anticoagulant protein C pathway. Viscoelastic tests, on the other hand, are superior tests of coagulation function in cirrhotic patients undergoing liver transplant compared with traditional tests. However, their capacity to recognize hypercoagulable prothrombotic status is questionable. An example of limited capacity of TEG to detect hypercoagulability prothrombotic status is this case of thrombosis right and left heart and distal aorta, secondary to the presence of antiphospholipid antibody detected post-mortem. However, TEG show a hypocoagulable state with severe fibrinolysis, almost a flatline TEG associated with bleeding. The administration of procoagulants, platelets, and even a small dose of antifibrinolytic was followed by hypotension, cardiac arrest, and right and left heart thrombosis. This is a case where fibrinolysis was secondary to and protective of hypercoagulable state induced by antiphospholipid antibodies. While NASH is becoming the leading cause for liver transplant, NASH is also the leading etiology associated with thrombotic complication pre and post-transplant. NASH itself appears to be an independent risk factor for developing thrombotic complication. Autoimmune conditions are also associated with perioperative thrombotic complication. Thrombosis in the pre and post-operative period affect definitely mortality and morbidity post-transplant. Thrombotic events also occur intraoperatively with a rate from less than 1% to up to 6% and are associated with over 50% intra and post-operative mortality rate. The usage of intraoperative transesophageal echocardiography during liver transplantation showed that those thromboembolic events appear more frequently than we thought. Microemboli after a perfusion in 40% of the cases, isolated right ventricular dysfunction in 22% of the cases, and intracardiac thromboemboli in other 20% of the cases. However, not all those events are clinically significant. Presence of intracardiac thromboemboli or biventricular dysfunction on intraoperative transesophageal echocardiography was predictive of short and long-term major postoperative adverse cardiac events. Going over the studies published in the last 10 years, and I extracted the factor associated with the risk of developing intracardiac thrombosis. Starting with systematic review published in 2008, thrombotic event can occur in every stage of liver transplant surgery and appear equally when veno-veno bypass or antifibrinolytic were used. Most frequent clinical symptoms included systemic hypotension, increased pulmonary artery pressure, and complete circulatory collapse. UCLA in 2010 reported that incidence of 1.9 intracardiac thrombosis, while TEE was used in 50% of the cases. Presence of portal hypertension and intraoperative dialysis were found as risk factors. University of Pittsburgh in 2012 reported an incidence of 4% intracardiac thrombosis, while routine TEE was used. Risk factor and diagnostic predictor identify were cardiac arrest, triple flatline TEG after a perfusion, flatline TEG anytime, fibrinolysis on TEG, severe post-reperfusion syndrome, hypotension, ascites, portal hypotension, pre-transplant hospitalization, or ventilator. 2015, Mayo Jacksonville reported a very low incidence of 0.36% of intracardiac thrombosis, while TEE was used in only 12% of their cases. They reported a mortality rate of 40% for patients with right and left heart thrombus, and risk factors identified were atrial fibrillation, TIPS, or prior venous thrombosis. In 2018, University of Washington, Seattle published a remarkable OPTN database study regarding factors associated with mortality within 24 hours post-transplant. Uncontrolled hemorrhage, intracardiac thrombosis, and primary graft failure contributed equally for the mortality within first 24 hours. They identify as risk factor for thrombosis, history of pulmonary embolism or portal vein thrombosis, functional status Karnofsky less than 20, preoperative ventilator support, diabetes, and Asian ethnicity. Also in 2018, University of Miami published the thrombotic events in multivisceral transplant, including the liver, where the incidence of intracardiac thrombosis was much higher than liver, up to 25%, while TEE was used routinely. TEG resembling DIC, R time less than 4 combined with fibrinolysis or flatline was statistically associated with thrombosis. In 2019, University of Wisconsin published their own series with incidence of 4.2 intracardiac thrombosis while routine TEE was used. All patients presented with acute hypotension and high CVP prior the event. Reported risk factors were high MELD, donor with high BMI, and long warm ischemia time. University of Miami in 2019 showed that fibrinolysis shutdown, defined on TEG as Li 30 less than 0.8, was the dominant fibrinolysis phenotype in liver transplant recipients, followed by physiologic fibrinolysis and hyperfibrinolysis. All intraoperative and postoperative thrombosis events occurred only in fibrinolysis shutdown group. Preoperative renal replacement therapy was strongly associated with fibrinolysis shutdown and intraoperative thrombosis. Multivariate analysis identified two pre-transplant risk factors for fibrinolysis shutdown: preoperative platelets counts less than 50,000 and NASH cryptogenic cirrhosis. In 2020, UCLA, while started using ROTEM, they reported an increased usage of cryoprecipitate from 1 to 3 units, and as a result, they doubled their major thromboembotic complication, defined as intracardiac thrombosis, pulmonary embolism, hepatic artery thrombosis, and ischemic stroke 30 days post-transplant. They found that intraoperative use of more than 2 units cryoprecipitate and PRBC more than 18 units were independent risk factor for major thromboembolic complication. The most recent case series was published by Henry Ford Michigan Group in 2021 with a reported incidence of intracardiac thrombosis of 1.5%. Risk factors associated with those events were systemic hypotension, cardiac arrest, and antifibrinolytic use. 5 out of 6 cases received antifibrinolytic. However, no timing and dose was reporting and no TEG data. Summarizing the last 10-year study, those are the pre-transplant risk factor associated with intraoperative thrombosis. If we ask our surgeon colleagues if we can give heparin thromboprophylaxis for a case with high MELD, portal hypertension, fibrinolysis shutdown on baseline TEG, on dialysis, with diabetes or atrial fibrillation, Karnofsky score less than 20, in the hospital or on the ventilator at the time of transplant, with portal vein thrombosis or history of other thrombosis, we know the answer is no heparin. Nevertheless, those represent a vast majority of cases coming to operating room. Why some of those cases develop intracardial thrombosis and some not, we don't know. What we know is that those events can occur in any stage of transplant procedure. Transesophageal echocardiography used routinely during liver transplantation make the diagnostic and intervention faster. Viscoelastic test needs to be done systematically to capture the coagulation abnormality. However, viscoelastic tests have limited capacity to recognize hypercoagulable prothrombotic status. There is a need for tests to make this distinction possible. Until those tests are becoming available, a routine thromboprophylaxis with heparin sounds like a reasonable plan to prevent those events. Regarding intraoperative clinical scenario of those thrombotic events, intracardiac thrombosis can occur on the right heart or right and left heart. Left heart thrombosis is associated with high mortality. If left heart thrombosis happens, we should rule out genetic of acquired thrombophilia. Intracardiac thrombosis usually associated with episodes of hypotension, increased central venous pressure, pulmonary artery pressure, or cardiac collapse. Those are preceding the event. TEG showing an activation of coagulation with short R time plus minus fibrinolysis or flatline TEG, DIC like TEG, are highly predictive of intraoperative cardiac thrombosis. Bleeding, oozing, out of proportion or surgical procedure is very common at this time as fibrinolytic system is activated by clot formation. So we see an increase in blood transfusion around the time of the clot. Procoagulants, platelets, and cryoprecipitate and antifibrinolytic usage during this period of DIC like TEG in the absence of heparin can precipitate the event. Incidental, we can see clotting of extracorporeal devices used. Everything is clotting. Cell saver, dialysis, or veno-veno bypass, or even clotting of heparinized ABG syringes or TEG sample. Marginal grafts was found to be also a risk factor in developing thrombosis, mainly after reperfusion. Obviously, once the thrombotic events occurred, no restriction in action to save patient life, like giving heparin, TPA, or asking for extreme measures like ECMO or cardiopulmonary bypass. Maybe it's time to think about risk versus benefit of routine thromboprophylaxis during intraoperative period. What drug, how much, when to give, safety, how to measure the effect if necessary, and its role in preventing DIC, disseminated intravascular coagulation. To answer all those questions, unfortunately, there is not much evidence except 3 retrospective descriptive studies documenting usage of unfractionated heparin routinely during liver transplantation. Ocean Medical Center, University of Miami, and University of Wisconsin. Ocean used 30 units per kilo heparin, average 2,000 units at the time of cable clamping in 39% of the patient, conventional transplant without veno-veno bypass. A 5-fold decrease in incidence of intracardiac thrombosis was reported with no increase in blood transfusion. None of the events occur in the presence of Amicar. University of Miami used unfractionated heparin 30 units per kilo at the time of portal vein clamping, an average of 2,000 units in 32% of the cases. Procedure was piggyback without veno-veno bypass. A clinical notable 3-fold decrease of intracardiac thrombosis incidence was recorded, with no increase in demands for PRBC of postoperative hemorrhagic complication. None of the events occurred in the presence of Amicar. University of Wisconsin was using 3,000 units prior cable clamping in 46% of their cases. A 4-fold decrease in incidence of intracardiac thrombosis was reported. Antifibrinolytic usage was not associated with intracardiac thrombosis. However, safety regarding transfusion requirement and post-transplant bleeding complication was omitted. What lab tests we can use to monitor the effect of low unfractionated heparin? We have 5 options. Each test used for end-stage liver disease has its own issue. Anti-10A is the gold standard. However, is a lab test costly and time-consuming, appear to underestimate the heparin effect in end-stage liver disease. On the other hand, APTT, activated partial thromboplastin time, overestimate heparin effect in end-stage liver disease. This is due to a decreased levels of antithrombi in those patients. Kaolin activated clotting time, kaolin ACT, was found to be unreliable when fibrinogen level was less than 140 and overestimate heparin effect in end-stage liver disease. HepCon HMS Plus provide whole blood heparin concentration measurement for low dose heparin, specific the red cartridges used in cardiac surgery to measure residual heparin effect. Thromboelastogram, R-time ratio, kaolin versus heparinase, can identify low dose heparin effect in whole blood. An R-time ratio over 2 was considered a significant heparin effect. Regarding DIC, Japanese Society on Thrombosis and Hemostasis proposed a new diagnostic criteria based on degree of fibrinolytic activation, underlying disease, and associated treatment. Marked activation of coagulation is the major pathogenic factor in DIC and is common to all DIC types, but the degree of fibrinolytic activation differs considerably depending on the underlying disease. As such, we have 3 types of DIC: suppressed, balanced, or enhanced fibrinolysis. As you can see, heparin is part of the treatment for all of them. Thrombomodulin and nafamostat is not available for clinical use in US. In case of liver transplant, the concept of DIC is unclear in all the aspects. What is the trigger, how we diagnose, and how we treat. For a better understanding of the concept of DIC in liver transplantation, using a Sakura diagram of DIC type, we match the DIC variants established to be prothrombotic in previous studies I mentioned, and also we match the corresponding treatment for each variant. Viscoelastic tests are unable to clearly discriminate a hypercoagulable prothrombotic state, especially whenever is associated with fibrinolysis. If severe fibrinolysis require treatment to maintain a balance between the coagulation and fibrinolytic system, the simultaneous administration of heparin may well be considered. Definitely preventing the development of DIC is better than the treatment of DIC when this occurs. Prevention requires suppression of coagulation activation, and low dose of unfractionated heparin is the solution. Are we ready now to use routinely unfractionated heparin during liver transplant? What you do every day matters more than what you do once in a while. Based on the evidence we have, unfractionated heparin given routinely at the time of portal clamping, piggyback, or caval clamping for conventional, demonstrate that there is a reduced incidence of intracardiac thrombosis, pulmonary embolism during liver transplant, all 3 studies. Does not increase intraoperative blood transfusion, 2 studies. Does not increase reexploration for bleeding, 1 study. Half time is 60 minutes, is easy reversible with protamine, usually after hepatic artery reperfusion, is residual heparin effect is still present and clinical bleeding. Viscoelastic tests can be used to monitor the heparin effect and also offer protection against consumptive coagulopathy. Perhaps the biggest challenge we are facing is how we can convince the surgeons that the small dose of unfractionated heparin given routinely at the time of caval portal clamping has its role in reducing the incidence of intracardiac thrombosis without increasing bleeding complication. While we can easily manage bleeding, thrombosis remains the challenge of liver transplantation with high intraoperative mortality rate. Thank you.
Excellent talk, and like 30 seconds ahead of schedule, which is always great. Awesome, that was excellent, very well put up. The next person that we have taking the con side of this is Dr. Satish Kumar from the University of Michigan, where he's an associate professor and director of transplant anesthesia there. He has a tough act to follow, but I'm sure he's up to it. And with that, I will turn it over to Dr. Kumar.
All right. Thank you, Kale. Can you hear me? Can you guys hear me?
Yes.
Okay. All right. Thank you for this opportunity. I think it's a tough slide to be on. Probably I know some of you in this group. I'm going to go over some of the con side of anticoagulation during liver transplant. So in terms of disclosure, I have a few grants, but none relevant to this talk. The biggest disclosure I have is that we do use heparin routinely in our practice in actually pretty high dose, pretty much for every transplant we do, unless we see some profound coagulopathy at the start of the case. So I just want to start off by showing this slide. I think what we're having in terms of discussion or debate today is not something new. I mean, this actually shows that this started back in the late 60s. This was a paper published after 13 liver transplants done between Cambridge and King's College in London. Essentially, what they did show there was that, I mean, they were equally worried about the clotting risk as we are talking about this evening. So they did report quite a high incidence of fibrinolysis, but they also kind of reported that there may be room to use anticoagulants. So the thinking about using anticoagulants is not something new. And I think we are still kind of questioning ourselves whether there's a role for anticoagulants in our routine practice. So the outline of the talk I want to give is why we need anticoagulants. And if so, what is the right anticoagulant we should be using in the setting of liver transplant? And what are the arguments I have against using anticoagulants, even though I do use in my practice? I want to disclose that again. And risks, and what are the perceived benefits we think we may kind of think maybe using using anticoagulants on a routine basis, and what is the evidence, and what should we doing as a society and a transplant community in the future in terms of strategizing or even developing some evidence-based practice towards using anticoagulants. So I want to start off by echoing what Nicholas said, that transfusion and outcomes in liver transplant is well known. And there's no question that there is increased mortality and morbidity associated with transfusion, which increases the ICU length of stay. There's higher incidence of renal failure in these patients. There's two studies I've quoted here. One was a single center, 400 plus patients, where they clearly showed that reduced 1-year survival related to Paxil and platelet transfusion. And another study with 900 plus patients had a similar kind of outcome. So I think we all need to keep that in the back of our mind, saying that transfusion and bleeding related complications do have an impact on postoperative outcome for these patients. So the question is that why are we even debating? Why do we think we need anticoagulation? Definitely, I think as Nicola alluded earlier, there is a higher incidence of prothrombotic state in patients with liver disease. The reported incidence of intracardiac clot is anywhere between 1 to 6%, depending on what study you look at. And there is regional clotting issues preoperatively in the form of portal vein thrombus, which some of the studies can code up to 10%. And this is more regional flow dynamics related issue than actually a general hypercoagulable state. The hypercoagulability can be just per se from the liver disease, or there may be a genetic component to it, which could be in the form of a prothrombin gene mutation or some thrombophiliac issues, which may be inherited. We also need to think through about some of the intraoperative factors, which could be catheter related, which could be from the tips. If you're a veno bypass user, then you may be wondering about placing those cannulas and the risk of those clots around it. Dialysis catheter could be pre-existing, which may contribute to the procoagulable states. And also exposure to antifibrinolytic drugs have been known to be associated with thromboembolic phenomenon. And on top of all those, we also need to think through about what are the other causes which may contribute to the prothrombotic state, which could be inflammation or sepsis or infection, which could be subclinical. Endotoxins have been associated with microthrombus. And ischemia reperfusion injury is something which we need to keep in the back of the mind, especially in the era of us using suboptimal graft and marginal grafts, which may contribute to the hypercoagulable state as well. I also just want to touch upon briefly on antiphospholipid syndrome. Although this is an inherited form, there are cases where antiphospholipid-like antibodies can be found in patients with chronic liver disease, primary biliary cirrhosis, autoimmune hepatitis, and patients with chronic hepatitis C infections. And there are case reports where these patients did not have a labeled diagnosis of antiphospholipid syndrome, but they were found to have antibodies similar to that. And this might have contributed to some of those thromboembolic phenomena they might have encountered during the transplant. So that what I want to switch gear is that I think it's not just focusing on anticoagulants. We also need to think through other causes or other factors which might contribute, which may need treatment more directed towards the pathophysiology of that liver, of those disease process, which could include anti-inflammatory agents like steroids, plasmapheresis, and other immune therapies on top of just using anticoagulation per se. No, none of these talks go without talking about the rebalanced state of coagulation in liver disease. I just want to, I'm not going to go too much into it, but just to quickly recap in the interest of the listeners. As we all know, the coagulation status in liver disease or end-stage liver disease is pretty tenuous. There's actually an equal reduction in both pro and anticoagulant factors. One thing we want to keep in the back of the mind when we talk about anticoagulation is this. So these patients do have hyperexpressed factor VIII and von Willebrand factor. They do have reduced amounts of protein C, protein S, and antithrombin 3. So I just want you to focus on these three things: protein C, S, and antithrombin 3. These are anticoagulant factors, which helps to maintain the state of coagulation in the body in a normal state. With this in the background, I just wanted no talk in this current time goes without talking about COVID. Not just the liver disease per se. I think we're seeing more and more patients with prothrombotic phenomena in patients who might have been exposed to COVID infections. I think there's something to keep in the back of the mind, especially we are still in the pandemic, and we may be still encountering patients who may have subclinical or might have had infection in the past, which may be contributing to more hypercoagulable state in the setting of liver disease. So switching gears, fine. I think we all agree there may be a role for anticoagulation. And what do we have as options to treat or use in the setting of liver transplant? Obviously, as the previous speaker mentioned, we don't have a lot of options other than this wonderful drug. And this is actually a book per se, just describing the history and evolution of heparin, which I think is a fascinating read if you want to read on your vacation or so. But the interesting part of this is that we all need to be grateful that this drug has been in practice and we are using it. This just gives a little historic evolution of this drug. It was discovered in 1919 by a student who worked in Toronto with Professor Howell. And then the rest actually came into practice by the early 90s, and expanded clinical use happened since then. And we also are in the era of low molecular weight heparin, which definitely has revolutionized the practice and in terms of patient care and monitoring, et cetera, down the line. It's great. We have heparin. Is heparin the right drug for these patients? Is heparin a good drug in the setting of liver transplant to prevent thromboembolic phenomenon? Maybe, but I'm not quite sure if this is the right drug, if it's really going to work for these patients. Before we delve into those, I just want you to focus on a few other things before you consider anticoagulating these patients. Oftentimes, we do see heparin-like substance being released, or you do see the pharmacological effects of heparin-like effects, which you may see on your TEG or ACT or ROTEM or whatever testing you use. One needs to be careful that we don't compound the coagulopathy, which may be created by these heparinides, which are typically released during the ischemia reperfusion injury from the endoglycocalyx of your endothelium. So the impact of these endogenous heparinides should also be taken into account when you're iatrogenic anticoagulating these patients with heparin. The next question I would have is, what is the impact on anticoagulation from a therapeutic endpoint? How do you dose them? How do you monitor them? And the next question is that when do you actually give heparin for these patients? I know we talk about a lot of those studies saying they gave it pre-clamping, but there are case reports saying intracardiac clot has been reported during the dissection phase of your liver transplant too. So this makes you wonder, is giving heparin just before clamping is adequate? Is that really answering the questions we have, or is it really kind of helping out in terms of preventing these thromboembolic complications down the line? So my next argument is that, fine, I mean, heparin is a drug easy to use, it's reversible, and the half-life is short enough that it should wear off from your system. But for heparin to work, you need to have endogenous antithrombin 3. As we saw earlier, in patients with the liver disease, antithrombin 3 could be either qualitatively or quantitatively reduced, or some patients may have an inherited thrombophilia where they may not have adequate antithrombin 3. So if that is the case, how is your heparin going to work in these patients? Is that just a false sense of security we have saying we did give heparin before clamping, if it's going to help in terms of preventing thromboembolic problems? So I think the reduced level or qualitatively or quantitatively reduced antithrombin 3 in liver disease is a big question to argue whether your heparin is even going to be impactful or therapeutic in the setting. Antithrombin 3 is needed for your exogenously administered heparin to work. And this work by both allosteric and bridging mechanism to exert the anticoagulant effects when you do administer to patients. Just to recap, I think if you do decide to give heparin for these patients, I think we need to keep in mind there is a potential for antithrombin 3 deficiency, especially if you're not monitoring, as a lot of places do. I think you may have to ask yourself if you're really doing any sort of good to the patient by giving heparin. But if you do suspect antithrombin 3 deficiency, there are two ways you can kind of address this. One, by giving antithrombin 3 concentrate. I think each vial comes as a 500 international units. But if you're using FFP, each ml of FFP would give you a unit of antithrombin 3 equivalent. The half-life of antithrombin 3 concentrate, if you do give it as a concentrate, is pretty long. It can last for up to like 4 days, but no one knows the half-life of the antithrombin 3 you give along with FFP. But I think most often we do end up giving FFP, so you can argue that maybe you do replenish some of the antithrombin 3, which may be deficient in these patients. So the next factor you want to focus on is your protein C, and yes, which are endogenous factors which actually contribute as anticoagulants in your body. Protein C usually kind of gets adhered to thrombomodulin and thrombin in the endothelial cells, and then protein S attaches to both the activated protein C, and then it separates out, and eventually it actually inhibits the thrombin generation, preventing intravascular thrombosis in these patients. So this is something to keep in mind as well when you think of approaches towards anticoagulating these patients and the underlying mechanism which may contribute to your thromboembolic phenomenon in liver transplant patients. So protein C, as we all know, is a natural anticoagulant mechanism in the body. So reduced activity of protein C or S may lead to kind of increased thrombin generation and intravascular thrombosis. So I think this is something we may have to think and keep it in the back of the mind as well when we are addressing anticoagulation options for these patients. So the switching gears, I think what we also need to know is the complex coagulation mechanism in the body. So this is by various other stuff, including platelets, coagulation factors, and fibrinolysis. When there is an endothelial breach, it exposes von Willebrand factor and it activates the platelet, and it generates a series of coagulation cascade. And eventually the end product is thrombin generation. As we saw, protein C and protein S are usually the regulators for preventing a big thrombin surge and increased thrombin generation, which eventually converts fibrinogen to fibrin. So this leads to the next question, is that I think our ultimate goal or the end game for monitoring should be how good is the thrombin generation, how quickly the thrombin generation happens, and how can we relate this in terms of hypercoagulability or hypocoagulability, which might be the best and gold standard test if we can validate in clinical practice to follow or guide our treatment in terms of anticoagulating. So if platelets are solely responsible along with other clotting factors in terms of thrombin generation, what is the role of platelets or antiplatelet agents in terms of anticoagulating during a liver transplant scenario, and there, especially if there is an option to use an antiplatelet agents? We all know that antiplatelet agents are not very forgiving. They do knock your platelet function off long term, or sometimes it can last for a few days. If that is the question, do we even have an option to consider using an antiplatelet agent, provided the rest of the clinical or laboratory picture is favorable enough to use an antiplatelet agent? I actually may argue some of the newer drugs like cangrelor, which is P2Y2A receptor antagonist, which acts on the ADP receptor, it actually has a pretty short half-life, and it's cleared independent of renal and hepatic function. So one can argue, is there a role for using these short-acting antiplatelet agents if needed around the perioperative phase of transplant to see if this may impact or reduce the incidence of thromboembolic or intracardiac clots in the setting of a liver transplant? I don't think there's any data on this in liver transplant per se. I know there are a lot of limitations, especially if patients are thrombocytopenic to start with. They may be reluctant to use these agents, but definitely the short-acting antiplatelet agents have been used in the setting of PCI and acute coronary syndrome. The next factor we want to focus is your von Willebrand factor. We all know that a higher or hyperexpressed von Willebrand factor has been associated with poor outcomes in end-stage liver disease. And there is decreased survival in patients with end-stage liver disease if they had higher levels of von Willebrand factor. And also higher levels suggest endothelial activation, which once again kind of starts the cascade of coagulation, and which may lead to increased thrombin generation. One question or one argument I may add to this community is that if von Willebrand factor is a culprit to cause endothelial activation and thrombin generation to a significant amount, should we still be considering using cryoprecipitate, which we are trying to replenish fibrinogen? We are actually inadvertently giving factor 8 and von Willebrand factor, which is already hyperexpressed in patients with liver disease. So is that time to change our practice, not just thinking about anticoagulation? Should we be changing our approach to using appropriate factors than just giving something for the sake of giving it? So that's something we may have to think in addition to thinking about anticoagulation as well in these patients. And the next thing is, let's say we do agree on giving heparin, or you convince your team or your surgeons. How do you actually give it? How much you give it? It's all up in the air. We use anywhere between 60 to 80 units per kilo. I know some centers use 30 units per kilo. So I think the dosing seems to be up in the air. So what is the right dosing? How do you monitor? How do you actually sort of redose? How do you reverse? I think that's $1 million question. We do have some bedside testing like ACT. But once again, there are some challenges with using ACT. As you see, there are a lot of factors which may affect the accuracy of ACT testing. As you all know, ACT was brought into practice because of the use of heparin for cardiopulmonary bypass and to come up with an endpoint or monitoring strategies so you can redose heparin as you need it. So I think ACT probably is questionable as a monitoring option in the setting of liver transplant patients with all this coagulopathy they may have underlying. So the next question I ask is that, okay, we are using heparin. Are we predisposing this patient to other risks with the hope of preventing a thromboembolic complication? This study was pretty small scale, but what I want to highlight from this study is that this included 33 patients who are actually started on anticoagulation preoperatively. 1/3 of this patient developed HIT, and anticoagulation with heparin or unfractionated heparin had to be stopped because of heparin-induced thrombocytopenia. So my question is that by exposing these patients to heparin, are we risking another complication in the form of heparin-induced thrombocytopenia? You may want to consider other drugs which they have in the preoperative setting, especially when they're treating portal vein thrombus by using direct thrombin inhibitors or direct NA inhibitors. But there are some downside because of the reversibility issues and potential bleeding complications during the setting of liver transplant. This is just a case report which highlights the issue, which I'm trying to kind of emphasize here, that we may invite a new problem and we may potentially compromise graft function if you do cause a heparin-induced thrombocytopenia in these patients. So the next question is that, okay, let's say we do want to use anticoagulants. I don't think we have in the current setup where we have a reliable test which would help us to predict the clotting or quantifying the bleeding risk in patients with liver disease. As I talked before, I think thrombin generation is probably the end game for the coagulation cascade. So is there any test which can reliably kind of help us assess the thrombin generation? I think thrombin generation tests have been in practice, or at least has been studied. I don't think we have anything substantiated or validated for routine use in clinical practice. But if we do have it, I think that might be a game changer to kind of quantify some of the bleeding or clotting risk in patients with end-stage liver disease. I think it definitely will help you to predict the thrombogenesis, the lag time, the peak in terms of thrombin concentration, and the endogenous thrombin potential may help us to assess whether the patients are hypo or hypercoagulable. I hope we have this at some point, but I think we don't have anything substantive to put this into clinical practice at this current time. So the next question I have is that going back to the antithrombin is heparin resistance. Even if you do give heparin in whatever dose you choose to give, what is the likelihood of developing or having heparin resistance? We already talked about antithrombin 3, but there are case reports and there are some studies which have shown if patients have been exposed to preoperative heparin in the 24 to 48 hours preoperatively, there is a higher incidence of heparin resistance. And patients who have had enoxaparin pre-op may have reduced response to heparinization. There are some non-antithrombin 3 mediated resistance which has been well documented, especially in the cardiothoracic population. IV nitroglycerin has been shown to cause increased resistance to heparin. And also heparin resistance can happen due to binding to platelets, chemokines, growth factors. And one interesting thing is that the fact that factor VIII is hyperexpressed in patients with liver disease, this has been shown to be associated with heparin resistance. So the next question is that how effective is heparin in patients we know have hyperexpressed factor VIII levels? We already talked about the monitoring challenges. I think what might be useful is functional antithrombin 3 assays in patients who are being planned to have liver transplant may give us an idea to see if these patients may be a responder or non-responder to heparin. I just put this on just for the sake of argument here. This is actually an animal study, and these animals did not have liver disease. But what I want to emphasize again is do no harm. If you're going to give heparin, based on this, we may need some human data, but there is actually, it's been shown that there is increased thrombin generation in 12 hours post withdrawal of heparin. So if you do give heparin intraop, you may be increasing the risk of thromboembolic phenomenon in the first 12 hours post-op. So what is the risk of increased thrombin generation in the post-withdrawal phase of heparin in human? I don't think we have any answer, but that's worth something to think about. So where is the evidence for use of heparin? I don't think we have a lot of evidence. This is the best evidence I could see. As you could see, it's not very robust. It's more personal preference, and I don't think we have anything to substantively say heparin definitely improves outcome or it actually causes more harm than anything. So I think this is where we stand in terms of evidence for using anticoagulants routinely in our liver transplant population. So my argument now is that, okay, there is a risk of bleeding, there is a risk of clotting, which is worse. What should we be doing? I just want to emphasize a couple of those studies which actually clearly shown, although they're old, there's definitely bleeding is not without its risks. And the incidence of bleeding based on this study is close to 10%, and reoperation for bleeding was associated with significant mortality, ICU length of stay, and hospital length of stay. And this is another study which included 700 plus patients from a single center, and they reported an incidence of 20% bleeding, which once again was an independent risk factor for mortality. So what I want to emphasize here is that bleeding is not without its risk. I want to summarize by saying that this balance is fragile. You really have to be careful that you don't tilt this balance one way or the other. I think we need to be extremely careful in introducing new interventions. We really have to balance the risks and benefits of preemptive intervention before we make an impulsive practice change. I think what we need as a society like this is to kind of start thinking of some multi-centric studies which may be able to give us some answer to see if we need to do a practice change. And if we do think there is a need for anticoagulation, what is the right drug and how much should we be using, and what are the outcomes going to be if we do start routinely using anticoagulation for this patient. I have no doubts. I think there are certain patients who definitely would benefit from anticoagulation. I think a blanket rule that everyone should be getting heparin pre-clamp or at some point during the transplant, I'm still not convinced. I think we definitely need more answers before we change our practice completely across the board. So I want to conclude by saying thromboembolic complications during liver transplant is certainly associated with higher morbidity and mortality. And one needs to ask, well, based on the literature evidence we have, the incidence of thromboembolic or intracardiac clot is close to about 6%. If the bleeding risk is anywhere between 10 to 20%, what is worse? We just need to balance those and think through before we make any practice changes. No question that heparin and TPA has been used in treating or preventing thromboembolic complications, but once again, the data is not robust enough to make a practice change at this current time. I also want to emphasize that bleeding complications from liver transplant is not insignificant, that we should be ignoring the bleeding risk in these patients as well. I think what we need is a balance between bleeding and clotting risks, and we need some robust therapeutic and diagnostic tools for us to make changes in terms of anticoagulating these patients. This was actually an informal survey which was done on a social media. I think we had about 65 or 70 responses. 20% of the centers use routinely, and 29% of those selectively use it depending on the patient comorbidities. So I think this just tells you the fact that the practice is still pretty inconsistent. I think there's definitely, I could see that there's increasing number of centers starting to think about using heparin. If we do want to use it, I still don't know what is the right dosing. When should we be giving it? Should we be giving it at the start of the case rather than just before clamp? Because there is a risk of clot at any stage of the transplant. So I think we just need to be careful in how we use it, where we use it, and we also need to be aware of the implications of routinely anticoagulating these patients. On that note, I'll stop here if there's any questions.
Excellent, thank you. That was great. I think this has already spurred some pretty good conversation in the chat, but we'll give some time here. If you have a rebuttal, Ramona, we can proceed with that, and
Yes.
we'll get to questions after that.
Okay. So, sorry. So if you are not convinced yet that we need routine heparin thromboprophylaxis on liver transplant, I will present an already published case of 60 years old hepatitis C, hepatocellular carcinoma with a biological Meldor 14, where DIC during liver transplant was clinically manifested after protamine administration. Based on the previous list of risk factors associated with intraoperative cardiac thrombosis, this patient had only fibrinolysis shutdown, Li30 on baseline TEG, and mild portal hypertension. DIC in this case was demonstrated by, as you can see, a gradual arc time shortening during the dissection and diffuse bleeding with hemodynamic instability not related to blood loss during dissection phase. Heparin 2000 units was given at the portal clamping. This was very short after this episode of hypotension happened. And TEG show a good heparin effect during the unhepatic phase with arc time ratio more than 5. What happened 30 minutes post-reperfusion? Heparin reversal by protamine unmasked the underlying DIC and unleashed its clinically and laboratory manifestation, including life-threatening intracardiac thrombosis on the right atrium, consumptive coagulopathy, and flatline TG tracing. Intervention in this case was another 4,000 units heparin, and while the clot size was decreasing in size, 20 minutes later, 5-gram Amicar was given to treat flatline TEG, which correspond with enhanced fibrinolysis DIC based on the Asakura DIC classification, followed by procoagulants, cryoprecipitate platelets, and blood products. As you can see, took hours to correct the coagulopathy once DIC was triggered. In conclusion, our case directly but strongly demonstrates the prothrombotic proclivity of flatline tracing and the efficacy of heparin thromboprophylaxis in restraining the clinical manifestation on DIC during liver transplant during the dissection phase. Unfortunately, protamine was given afterwards, and that's when the clot happened. Regarding what actually triggered the DIC in the beginning, on this particular case, we did a TEG using patient blood and his ascites as part of an ongoing study. Shockingly, TEG show a DIC type TEG, extremely short arc time and fibrinolysis. Could the ascites, which appear to be prothrombotic in vitro, be the trigger of DIC during dissection phase, which we had when we had the first episode of hypotension, We cannot deny that the direct contact of ascites with dissection surfaces is likely possible. Coagulopathy is a well-recognized complication of peritoneal venous shunting for ascites done in the past, Levine or Denver shunt. The relative contribution of primary fibrinolysis and DIC remain controversial. Many studies are documented the increased fibrinolytic activity of ascites. However, primary fibrinolysis may be hidden by the secondary fibrinolysis, which makes us think that not all ascites are the same. Until we have a better understanding or better test to identify hypercoagulable prothrombotic state during liver transplant, small dose heparin before an hepatic phase can prevent activation of coagulation, even if that's happened during the dissection case, and has the benefit of reducing the incidence of those devastating thrombotic events during liver transplant. To the dose of 2000 usually doesn't last more than 1 hour. Exactly, you reperfuse the hepatic artery and the effect is over. So very often you don't need any reversal. So what we are doing in case of HIT and when we really need to use anticoagulation. Pre-transplant, we need to rule out the HIT by sending a HIT panel if you know that the patient has a HIT. And if on the day of surgery, HIT was diagnosed more than 6 months, for the time of surgery is okay to use heparin. However, postoperative heparin should be avoided because the risk of HIT recurrence of 1.3%. In case of HIT intraoperatively, we can use bivalirudin, an antithrombin with 25 minutes half time, partially reversible by CVVH, and can be used as bolus or, if necessary, as infusion. Those needs to be adjusted based on creatinine clearance. Post-operative, heparin should be avoided and treatment differ based on acuity. For prophylaxis, fondaparinux, indirect inhibitor of factor 10, versus for high-risk thrombosis or thrombotic event, bivalirudin continuous infusion with different anticoagulation targets can be used. Thank you.
Hey, Ramona, I have a quick question related to HIT. So, I mean, we follow the same thing. If their antibodies and SRA screen has been negative in the last 3 months, we always agree to give 1 dose of heparin for the intra.
Should be 6 months. Should be 6 months.
6 months. So, my question is, what is the risk? I know there's case series and reports of what's the risk of the donor getting systemic heparin, which the recipient can get exposed. Is that a contraindication, or is that something you kind of accept that's a risk you take? So
you accept that as a risk you take. There is nothing you can do. But
I mean, my question is that would you still give a bolus of heparin for your cross clamp, knowing that we have already exposed this patient to heparin?
So if I know that it's a real HIT diagnosis, then I'm not going to give it. So it's either I'm taking my chance, or if a clot is going to happen, then I'm going to give bivalirudin, or I'm not going to give heparin in this case, unless really actually you can use it as a bolus. The effect doesn't last more than 25 minutes. So that's the benefit of it. Very short-lived. So that's why they recommend the continuous infusion if you really need to keep the level, to maintain the level.
All right.
So
awesome. Yeah. See, we have a couple of questions in the chat, and I'll kind of direct them to both of you, I guess, in this case. But one of the questions was about exclusion criteria in studies promoting heparin use. Were they for all livers, acute liver failure, chronic liver failure, acute on chronic? Were there any distinctions for that?
Yeah, usually for everybody we were using. So no exception, except the HIT. HIT, it's tricky. So that's why, and especially that we are doing multivisceral, and most of the multivisceral have HIT diagnosis in the past, so that's why we put up this protocol of HIT protocol. So far we didn't have a chance to have a liver transplant with HIT itself, but we have a protocol for it.
Another question was, is there any utility in monitoring the coagulation index on TAG and using that to decide on the use of anticoagulation?
So we use the TEG, R-time ratio. So we really want, especially if we see signs of DIC, the R-time ratio to be over 5. So if we plan to give antifibrinolytic, especially if we had signs of DIC like the case I presented.
Perfect. Another question here on the use of antithrombin 3. Are you guys using that at your centers, and would you recommend using
Usually the FFP has antithrombin 3. You give 2 FFP and your level goes almost where it should be. So that's the way how we do it. No antithrombin 3 concentrate.
Another question I have, just looking at all these questions, I'll kind of give for both of you. It seems surgeons are often perhaps the biggest roadblock in these decision makings. For both of you, I guess, since you guys are using this routinely, what was the trick or the way you were able to sort of convince the surgeons this was a useful and productive thing to do for routine?
So very tricky. The surgeon says, give it, but don't tell me. So we play that game. So, however, whenever we really feel that, you know, or we communicate, this patient needs heparin. So he said, no. Okay, this patient needs heparin. No. So we re-emphasize a couple of things, and then here we go, we have a clot, then you make your point. So I think that's the way, you know, and the experience and the 3 studies I presented, there is a reduced incidence. So if you can reduce the incidence 3 to 5-fold, not completely to 0, I think it's something, because it's really painful to deal with those events in the operative room. So you really don't sleep couple nights afterwards. So not us, not the surgeons, hard for the family, hard for everybody. So, and I think 2000 heparin is like nothing, let's say. I did a study trying to see what's the optimal dose, if it's 2000, 3000, 5000. So I used the HepCon used for the cardiac and the anti-10A to validate if 2000 giving at the time of caval clamping will last until hepatic artery reperfusion, and was like a pretty good correlation. So that's why for me 30 units per kilo is the right dose. And no increase in blood transfusion and no bleeding complication, no stroke. I think you will see more stroke, and I think Mayo published a couple stroke events by having intracardiac thrombosis with, and they gave TPA and then stroke. So, you know, TPA itself is not benign.
So in terms of our practice, I think our surgeons actually would ask for it. They'll start talking about heparin as they're getting close to anaphatic. And actually we do probably, out of all the chat I've seen, I think we do a pretty hefty dose compared to the rest. And our trigger was, we had a run of intracardiac clots. And I think that was enough for them to be traumatized, that we said, okay, it's worth taking the risk of bleeding than having an intracardiac clot. So I think we pretty much, unless I or our team says no, we routinely give heparin. Actually, this was the push came from the surgeons more than us. So we routinely anticoagulate pretty much all our patients.
So whenever I first came to University of Miami from Ochsner, where it was routinely, okay, I got the surgeons on board. We did routinely for 3 years. So all of a sudden, they decide to, let's say, we're not giving heparin. Let's see, we'll see if we are bleeding more or less. So that happened in November. So since November, we got 3 clots. So now we'll see if we can convince them back to go back on our routine of heparin prophylaxis. So here we go.
Excellent. I think I was gonna, Dr. Susan Mandel's on the call. I was wondering if she would speak a little to to comment on this topic we've had today.
If not, Susan, can we get Ted Sakai?
Sorry.
Oh, so
Sorry
Susan,
for the
perfect, good.
technique.
Thank you, Susan.
Apologize. So I just missed that because I just walked away for a second.
Oh, we were just wondering if you had any comments on your experience or with anticoagulation for liver transplants.
Well, thank you very much for asking. And I just have to tell you, first of all, how wonderful listening to both of these talks today was and how much I learned from it. You know, the whole issue to me is still very, very, very confusing. And I still don't know what the right thing is to do. And I think I probably share that opinion with many people out there. However, I have to admit that in times when I was dealing with very, very sick patients, I did give them antithrombin 3 because when I assayed a series of very sick patients with very high MELD, the antithrombin 3 levels were often less than 10%, which you know is extremely low. And that itself can give rise to thrombosis when you have such insufficient levels. And the problem is that when I looked at the literature on the antithrombin 3 content of FFP, it was variable from 0 to, all the way up to usually about 40% of requirement. And so I never knew how much antithrombin 3 I was giving in FFP, so I would give antithrombin 3. And I had my experience, my personal experience with that was very good. But then I think listening to everybody is that maybe there's not one size fits all here because the surgeons differ. And some surgeons do things where clot is more likely, flow is diverted, and that we've got a long road. We have a long road to travel with this, and I'm just not sure what we can do for the next step. I really like Satish's idea very much of somehow having some better monitoring of coagulation, because we're still looking at overall clot formation, which is the end result. And we have no way of monitoring what goes on at the vessel surface, which I think is what we're missing. That's probably where we get bitten from behind. So those are my only comments, and congratulations to the 2 speakers. Absolutely fabulous.
I agree. They were great. I was wondering if Ted Sakai, if you had any comments as well on the topic.
Yeah, thank you very much. Congratulations, Ramona, Satish. This is a very difficult topic, and then so the probably key word is routine. Whether we accept the routine heparinization or not, I would advocate at least selective heparinization. So dosage itself is the same, 30 unit per kilo. So it's very, very small dosage, 2,000 or 3,000 before the portal clamp. In our institution, the beginning of the anhepatic phase is the veno-venous bypass because we use the veno-venous bypass routinely. So that's the indication. How you decide whether you give the 2,000 or 3,000 heparin or not in our institution? Well, it depends on the TEG. And then I personally routinely check the pre-bypass TEG, which is a scheduled test. And then if it's normal or hypernormal, in that case, that's the indication. I can convince the surgical team, hey, this is just a sniff dosage, and then it will prevent the thromboembolic complication. Oh, by the way, we suffered so much in 2000 and 2006. And then, so that's the reason we have an institutional memory among the surgical team and anesthesia team. And then given those incidents, they're quite accepted for our indication. And then just in case if a thromboembolic episode is taking place, there's a question about how much dosage of the TPA. Well, you have to give it. Either you see the patient without having a TPA and then die on you, or you have a chance to recovery. So we have a institutional protocol in place with the surgical teams because there's no argument, in the case of the subcardiac arrest. So we have a TPA readily available, 2 milligram times 2 vials in our anesthesia cart. In such a way, if something happened and then hypotensive episode and then TEE shows you intracardiac clot, and then we assume that this is because of the pulmonary thromboembolism. In that case, we just kind of don't show the TEE to the surgical team, and then we give the 0.5 to up to 4 milligram of a TPA. So those agreement has to take place before those incidents happen. So as Ramona alluded to, communication with the surgical team during or ideally before those incidents is quite important. So we have a protocol inside the surgical and anesthesia department. So, but anyway, so a very important topic, and thank you very much for organizing everything, Kayla and Ryan, and then of course Ramona and Satish. We learn a lot.
The question I would like to pose is that, I mean, the 20 to 30 units is fine, but a lot of the surgical technique of clamping is variable, right? So I mean, a lot of centers do bicable clamp. Does that impact your dosing, or the stasis caused by bicable clamp? Is that similar to a partial or a cavostomy clamp?
So perhaps if it takes longer than 1 hour, I give half of the dose. So definitely, you have a long and hepatic, I will repeat the dose. Also, we have another thing we do, we give 1,000 units of heparin to dialysis if we are running intra-op dialysis. So every hour till unhepatic. So in unhepatic, we give an extra dose of 30 units per kilo, or based on the TEG, depending how much heparin effect I have on the TEG.
All right, excellent. I don't see any other questions in the chat, so I thank everyone for your great discussion in the chat, great participation. These were 2 excellent talks, as everyone's noted. So I want to also make mention this webinar will be recorded and posted to the website in the next few days, I believe, and will be able to be viewed from there. So thank you everyone for your participation and in this excellent talk, and have a great evening.
Thank you.